First Ave, Cedar Ridge. You're on.
Good afternoon. It is 2 p.m. on Wednesday, September 25th, 2019. This is a regular meeting of the Health and Hospital Committee. I don't think that worked. Shoot. It is Wednesday, right? Okay. I know you all heard that. Good afternoon. It is Wednesday, September 25th, 2019 at 2 p.m. This is a regular meeting of the Health and Hospital Committee.
Good afternoon, ladies and gentlemen. This is the 2 p.m. meeting of our Santa Clara County Health and Hospitals Committee, and since that time has arrived, we're going to begin with the call to order and ask the clerk to please call the roll and establish the presence of a quorum.
Vice Chairperson Ellenberg. Chairperson Simidian.
Here.
You have a quorum. Thank you.
All present and accounted for, including the various representatives of our staff who are here. Thank you for that. It takes us to public comment. That's item number 2. Public comment is that portion of our agenda set aside for comment by members of the public on non-agendized items properly within the jurisdiction of our county. We do have just one card today, Madam Clerk, and that is from Scott Largent. Mr. Largent, if you'd like to come down. As you know, we set aside up to 3 minutes for public comment, although the board cannot act or even engage in extended conversation about these non-agendized items. Welcome.
Thank you. Good afternoon. All right, let's get the
I think we're good
clock
to go.
going. All right, we're back in business. I went to the, good afternoon, Scott Largent. I went to the homeless summit that we had at the fairgrounds this last weekend. I do attend almost all these different events like that. I do think it's kind of a dog and pony show that nothing will ever materialize after that event. I go there not to rub elbows with politicians and not for the free food. I go there to talk with other homeless people that have kind of been in the same situation as myself. This old elderly gentleman, he's disabled, he's living in his motorhome, and the city of San Jose proceeded to implement a municipal code that he's violating the law by living in his motorhome. So he's just trying to survive on the streets of San Jose. And this poor elderly man, they're trying to sock him with a ticket for $2,285, okay? And just things like this. Now, he put together this really nice letter. I mean, I guess I should provide you guys a copy of this, but I just don't think anybody ever really pays attention to this. That's why I talk to the public right there. It explains everything that happened to this poor man. And now they're trying to run him through the Homestead Courthouse over there, and it's no longer like a traffic ticket, it's actual misdemeanors. So as a county, since he's an indigent client, I really do think we need to get this guy the proper legal defense. Now, not just on the criminal level, how do we send that message back to San Jose that this is unacceptable? I think the county needs to get this man a civil attorney, and we need to file a lawsuit against the anti-democratic city of San Jose. Now, this is not like suing our foot. We are the county, that's the city. We have to stop this activity from happening right here. This poor old man is just trying to survive, and this is mean right here. I pulled some of my older records that I have, and let me see where I've got, oh, there's a picture of Willard, my motorhome that I was living in. Let me see where I have it here. What I brought with me was a list of tickets that I got, and they're somewhere around here. Sorry about this. Yeah, well, I got tickets on private property. When I was living in my motorhome, I had permission from Pep Boys to be parked there. I cleaned the parking lots. San Jose PD kept giving me tickets for my motorhome. You can't do that on private property. They kept stacking these tickets up. Then they did the same thing with my work truck. They started giving me tickets. Then they started putting pressure on Pep Boys to have me booted and removed out of that parking lot. Now remember, I had permission. I wasn't breaking the law. They want to get me off private property so then they can take my motorhome, rig the cases, and this is what they're doing with our homeless community here in Santa Clara County. So you people, as our leaders here in Santa Clara County, need to start standing up for these people. Start getting them a better legal defense other than just criminal court. They need civil attorneys. They need somebody to fight for their belongings and their property. So I would appreciate some type of help. Thank you.
Thank you. Let me confirm we have no other speakers under public comment. We do not. Takes us to item number 4, which is to consider recommendations relating to medical staff. And here to present with us today is
Yvonne Karanis. I'm the president of the Enterprise Medical Staff. Thank you very much for having me this afternoon. I'm here to present the credentials report and answer any questions if you have them.
Thank you. My question is why I forgot to approve the consent calendar item before I came straight to you. Thanks for the prompt from the County Counsel's office. But we're going to go ahead and do you since we're on item number 4 and we don't want to keep you any longer. This is a regular monthly event. We are simply being asked to approve the appointments and reappointments. And I'll look to my colleague, Supervisor Ellenberg, and unless she has comments or questions, I'll ask her if she's prepared to offer a motion to approve the recommended action for item number 4.
So moved.
She says she's moving item number 4. I'm going to say, I'm going to second that. Are there any comments or questions from members of the public, Madam Clerk? There are not. Then without objection, hearing none, unanimously approved. Thank you.
Thank you very much.
That takes us back to item number 3. Forgive me. We do have a very brief consent calendar today. And do we have any speakers on the consent calendar, Madam Clerk? We do not. Anybody need us to pull anything from the consent calendar? Apparently not. Ms. Ellenberg, would you like to move to approve the consent calendar as contained in our published agenda?
Move approval of the consent calendar.
Second, without objection and hearing none, so ordered. It's approved. Okay, that takes us through items 1, 2, 3, 4. And now we're at item number 5. This is an item, of course, that was held previously. And I should just mention Mr. Marquez, and for folks at the Health and Hospital System, I know we had apparently a few process hiccups in terms of arranging the agenda this time. We really are in my office, and this is at my direction, calling out items that might otherwise be considered under the general reports, which we call accountability reports in our office. So I know there were some folks like, no, they go here, no, they go there. No, the answer is the whole point of this new approach in this committee is to pull them out and without siloing them, make sure they get the special attention that they deserve. So please understand that's the goal as we go forward. Okay, thank you. That takes us then to item number 5, receive the report from the Emergency Medical Services EMS team relating to the status of the EMS agency and EMS system for calendar year 2018. Who would like to present? Could you both introduce yourselves, please?
Together. I am Jackie Lowther, the EMS Director for the EMS Agency for the Santa Clara County.
And the gentleman seated to your right is?
And I'm Ken Miller, the Medical Director.
Thank you.
So, members of the committee, good afternoon. The annual report before you is for the year period ending in December 2018. And I'd like to highlight a few items from the report before we open it up for questions. The emergency medical services capabilities and expectations have expanded significantly over the last decade. EMS is an essential factor in the healthcare equation, and the quality of the work is crucial. The transformation of the EMS system to a data and quality-driven organization requires a collegial partnership with all our community stakeholders in the entire system, and it is an integrated healthcare system. The EMS agency is patient-centered, quality improvement, data-driven agency with regulatory oversight over a very complex, sophisticated emergency medical service system. Our system serves just under 2 million county residents covering 1,132 square miles, averaging 338 responses per day, 224 transports, about 1 call every 4.5 minutes to 11 receiving hospitals. The emergency EMS agency is responsible for permitting all organizations and vehicles that operate in the system, and we currently have 132 non-911 ambulances and 85 911 ambulances, which includes 18 from our fire jurisdictions that respond to calls. The fire jurisdictions do include do respond during low system volumes, or when a county ambulance has taken about 18 minutes or so to respond to a call, or if the patient is in extremis. We have 8 EMT programs, 2 paramedic programs, as well as 19 continuing education programs. We do have the approving authority over the permitting of these providers, and we ensure quality of all of these programs by auditing at least 10% of all of the classes that are provided. To date, the most frequent type of call we still go on is traumatic injuries. We've had about 26,000 patients that have called with a complaint of a traumatic injury. But it is good to keep in mind that trauma can include anything from an injured arm to multiple traumatic injuries, say from a motor car accident or motorcycle accident. One of our main focuses has been to reduce the time ambulances wait at hospitals. We've been trying to get this number to 25 minutes, 90% of the time at all of the hospitals in Santa Clara County. This improves access for all of the ambulances within the county, and we've been working with all of them. It is important to note that the hospital demonstrating the greatest improvement has been VMC. Last year, it was at about 50, anywhere from 45 to 55 minutes. This year, they're at about 32 minutes. So they've improved both on wall times as well as bypass. And bypass is the other area that we look at, because there are circumstances when hospitals can request ambulances bypass their facility due to patient load exceeding either ED or specialty resources. And so we measure bypass, and it is a metric which shows us how the system is functioning on a daily basis. And all hospitals need to provide to the EMS agency their ED surge plans, and they provide this to us in October. One of our key important issues in the entire healthcare industry is data, and EMS is no exception to this. We've been focused for the last 10 years to capture information from the moment 911 is called until the patient is discharged. The electronic patient care record, which we use as ImageTrend, was implemented in 2016 to a great expense, which unified the first responders as well with the hospitals and county ambulance. So what we're hoping and what we're working toward is a health information exchange. When the HIE, or the Health Information Exchange, is fully implemented, it will assist in the integration of the raw pre-hospital patient care data into the receiving hospital's electronic medical record system. This will be for the documented 911 event that required the patient to be transported. Then it will facilitate the exchange of the hospital's outcome data for this specific event that the patient was transported for to be returned and associated to the pre-hospital PCR, or the patient care record. This will allow for a full patient care picture to be seen, taking into consideration the privacy of the patient. There's a lot of negotiations that have to be implemented and started on this trail, and it's going to take us probably about 3 years to get through this process. And over to my esteemed colleague to talk about cardiac arrest and stroke.
And other things, sure. So in 2018, we implemented a high-performance CPR program that doesn't change fundamentally the physiology of CPR, but we changed more or less the choreography of CPR in a way to prioritize chest compression as the initial intervention, aiming for quality markers of depth, rate, full release, and then to optimize or maximize really chest compression fraction, meaning to minimize pauses between chest compressions. Follow that with defibrillation, a basic life support airway and ventilation, focusing on rate and volume, and then transitioning to an advanced life support airway and drug therapy. That training began in late 2018. It took about 15 sessions to get 115 first responder trainers familiar with the program. From there, they continued throughout the fire departments and the ambulance providers to train about 3,500 personnel in high-performance CPR. That was implemented in January of this year. So we are, now beginning to collect data to evaluate the effect on both the pre-hospital return of e-pulse circulation and, more importantly, the neurological survival from hospital discharge once delivered to the hospital. So that'll be part of our 2019 cardiac arrest data evaluation. Regarding stroke, nothing much moves faster than stroke does these days relative to the science. 2018 was the first full year following the implementation of a stroke severity tiered decision strategy for delivering patients with the highest acuity directly to a comprehensive stroke center.
Excuse the interruption.
Yes.
Full disclosure for my, excuse me, for my colleague. Is it fair to say that I pushed that at this committee?
It is extraordinarily fair to say.
And is it fair to say that there was some pushback from some of the hospitals initially?
That's true.
Okay. So rather than just have this be a sort of a nice once over, I sort of want to tease that out now and have you say, so how's that working out for us in your best professional judgment? And what is the thinking among the various hospital stakeholders today?
Yes. Well, it certainly has become institutionalized throughout our healthcare system and our EMS system. So we no longer have resistance toward the strategy for primary stroke triage for the highest acuity. And our colleagues around the state, by the way, only 3 other counties in California have a stroke severity score tiered stroke system. Los Angeles is partly deployed. Of course, we are fully deployed. Ventura and Yolo. So this is in the lead of stroke care for EMS systems. Not to stop there, though. However, the science has advanced. The current strategy goes to both a high acuity presentation as well as a time frame for presentation. The key studies published in late 2017, early 2018 focus on imaging strategies that will provide a better perspective on the survivability of brain tissue, and that time frame alone is less important. So beginning with our training about to start actually this October this year and implementing in 2020, we will remove a time frame requirement for symptom onset for direct to comprehensive stroke center triage and rely entirely upon the severity score. So that's the frontier for stroke. On the front of ST elevation, myocardial infarction, a certain type of heart attack. Following that 2018's data, we are striving to improve the time frame between that first medical contact by EMS and the acquisition of that first 12-lead ECG. The purpose then is to stimulate the preparation for receiving hospitals in order to decide which patients will be candidates then for a vascular intervention. That and improving our 12-lead ECG transmission capabilities across fire departments as well as the transporting ambulance company. The community paramedicine project continues on with the Gilroy Fire Department. That started in April of 2018. Within calendar year 2018, there were 89 patients that participated. We are up to 179 now. And principal findings there go to the prevalence of adjustment disorder as being far greater than serious mental illness. And that program continues now through November of 2020. And finally, I'll conclude this with 2018 also was the year for essentially a rewrite of our multi-casualty incident plan. It went to a variety of changes that were learned from many large incidents around the country and indeed around the world. It was developed in 2018, trained to in late 2018, implemented in 2019 February, and it was used July 2019. At the Gilroy Garlic Festival active shooter incident. So I'll pause there and toss it back to you.
We do look forward to continuing the delivery of the highest quality patient-focused care through collaboration, facilitated regulation, and system management. And before we go any further, we'd like to see if you have any questions on the annual report.
Supervisor?
Thank you both very much for this report. I do have a couple of questions, Jackie. They are for you. Two regarding the EMS services. What are the steps that are planned to further reduce the impact of the VMC Emergency Department renovations on EMS offload times?
On the renovation, I would have to turn it over to my esteemed colleague at the dais over here. We have been working with them on a continual basis on offload time. And as far as their renovation timeline, I'll have to turn it over to Paul.
Thank you, Supervisor. So the renovation project for the ED will begin early 2020. We anticipate the project to range between 3 to 4 years at the most. We are going to operate the emergency room in terms of its construction in phases relative to our ability to manage all the current patient loads that we're experiencing today.
So you don't anticipate greater numbers of bypass as a result of the construction?
We are going to do everything possible to manage the current patient load within our facility as it exists today, even during the construction.
Okay. My next question might be better directed to you as well, but Jackie, feel free to jump in. One of the things I learned on a recent EMS tour was the number of 911 calls that are coming from within the campus to transport a patient to the emergency room. And I assume that this has been brought to your attention as well. So I'm curious if there are plans to adapt this system to use the non-emergency ambulances for this kind of work, and maybe some training around when external 911 should be called within the campus.
Thank you, Supervisor. So for the past couple years, we've been working very hard to train and educate our staff on when it's appropriate to utilize the 911 system. So while there are outpatient facilities on the campus of Valley Medical Center, it's a very large campus, in all situations, these facilities do not have the capacity to respond to true 911 medical emergencies. And therefore, we are required to rely on the 911 system for the immediate response and transport of that individual. But the real key here is for us to continue to educate our staff of when, in fact, it is a true 911 medical emergency. And we will continue to do that. And I think over the past couple of years, and Jackie could probably speak to this, we have seen improvement. The numbers are small in total in terms of the total 911 system, but there are opportunities for which we continue to look at.
Okay, thank you. And Jackie, thank you so much for really highlighting the collaborative approach that's being taken in planning for this process. I understand that you're waiting for some information still on procurement for RFP timing?
RFP for the HIE?
Right.
Yes. We're in the process for a collaborative. There are multiple systems that are trying to work on this HIE, which is a large project because, as you know, not only working with multiple hospital systems, but also things like privacy and ensuring that all of the documents only go between hospital EMS and not back into the wrong way. So I think it will take quite a while to get there. There is state regulation on this topic that all EMS systems will have a hospital information exchange, but we're right at the infancy of this. But it really is an exciting, it was great to get the first responders to EMS and the ability to actually get those records into the hospital through the hospital hub.
It really is exciting work. I imagine it's a little bit premature to start asking for a detailed timeline, but we can come back to that. Why don't you continue? Because you may answer my additional questions in the rest of your presentation.
Before we do that, however, I want to, we're going to get to the issue of on time compliance in the next segment of your report,
Right.
yes? And I did want to stay on stroke for just a minute. And I was serious with my intervention because what I wanted to do was stop and pause and sort of provide reassurance for myself and perhaps for others. You know, one of the challenges of being a layperson on a body like this one in particular is that not only do you not have certain technical or professional expertise, but you are sometimes called upon to referee a difference of opinion between professionals who will assert that they absolutely positively know what they're talking about, even though they have diametrically opposed points of view on the same subject. And we had a little of that with the stroke issues. And I'm always happy if we're the first or the most or the whatever, but mostly I just want to make sure we're doing the right thing. So now that we've had some experience, are you all convinced and feeling certain that the path we've taken with the corrections or adjustments that you've described puts us in the right place, that we're doing the right thing from a medical outcome standpoint?
Yeah, I think we are. And our sister agencies around the state, I believe, are trying to follow where we're going because the delivery of the right patient to the right hospital the first time is the holy grail, really, of EMS.
Yeah.
And with certain diseases, like STEMI, for example, there is a test, the 12-lead ECG, that is fairly objective, not foolproof, but fairly objective. Stroke is much more nuanced. In fact, I would argue to some degree that one of the few remaining places in medicine that decisions are placed on a physical exam is in EMS. There isn't quite the level of testing capable in the field that can give you the full assurance that the patient you see with stroke-like symptoms has a stroke of the nature that will benefit by direct transport to comprehensive centers. But the clinical triage is reasonable, and I think we are in the right direction. Certainly, it's following the literature.
Thank you. Thank you. Please proceed. Go right ahead, Ms. Lowther.
And part of our, if there's no other questions on the annual report, I'd like to just take a moment before we go to the other report to thank all of the EMS staff who have worked diligently, all the EMS duty chiefs who work on a daily basis 24/7 on their rotations to cover the county and who all participated in the making of this report, all of the agency staff. So I really want to thank them all. Just take a moment for them. And on our monthly update, we had actually a lot to say, to get across and to let you know all system providers are meeting their response time standards as of July 31st and as of August 31st. We have to get all this information in early in the month, so we're running a little bit behind. There has been no change of deployment. I monitor it extremely closely. In fact, Dr. Miller and I both monitor them probably as close, if not closer, than their management team does. So we do. And if I did put a map on the very last page of the report, so for your perusal, so that you could see exactly what those zones were reflecting to, because the code 3 response for zone 1, 2, 3, 4, 5 is the direct opposite of your districts. So I wanted to make sure that you were aware of what these, what those zones were referring to. So because they are in conflict with your respective districts. So they are responding. There may be a glitch, as some of you may recall In the Seventh Amendment, they wanted, and Supervisor Semidian had come to your, had mentioned about them and canceled calls. So next month's report will have a report on their canceled calls. So we will report on that next month. We also convened a stakeholder group to explore and define options and structure of the EMS system in Santa Clara County after the current non-exclusive 911 ambulance agreement ends in 2022. Our initial meeting was August 28th. Our second meeting was this morning. Our first meeting was really just an initial kind of getting to meet some of the stakeholders. We convened a group from various groups, city managers group, the fire chiefs, EMS chiefs, and let's see, who else is in that? County communications, the hospital council, the county executive's office, EMS, and who am I forgetting?
County council.
County council, of course we have county council there. But it was really an exchange of ideas to talk about patient-centered focus, how we would back into an RFP if that is necessary, regulatory changes that are happening in the state and data. And we submitted, I think, the minutes for you just to get a perspective from everybody. We submitted the EMS guiding principles just to get us started. And today we basically zeroed in on sort of dissecting a call. What do you do from the time 911, somebody actually picks up the phone to call 911? It was an excellent meeting, and it's going to take us a while to really get into really getting into the meat of all of this, but I think that's exactly where we want to go. We anticipate updating you on a monthly basis on the minutes and how we are progressing through this process to keep you, as well as we'll be forwarding that information on to the board. But we wanted you, and that's why it was so brief, because we wanted you to be the first to hear it. So feel free to ask any questions that you would like. We also are talking about adding a consultant, and then we will develop this timeline, which I know is very sparse, but it was just sort of an initial timeline to give you an idea, and it needs to be further developed into a more descriptive work plan for you. Questions for both of us?
Supervisor Ellenberg? Ms. Lowther, I'm looking at the document Emergency Medical Services Department Monthly Update, September 25, 2019, 5B, and it's a 4-page document, packet page 53, 54. I just want to make sure I know what I'm looking at. When we're talking about contract ambulance performance, we're looking at the grid of 90+% numbers. We're looking at a grid that deals with our ambulance response rates, not our first responder response rates provided by the various first responding agencies, fire districts for the most part. Am I correct?
Correct.
Okay.
This is our contractor only.
Right, thank you. So as you know, a source of concern to me over the last half dozen years has been the ability of our first responders to get there on a timely basis. And I'm surfacing this for two reasons. One is because I want to get an update and want to know how we're doing after 6 years on this myself, but also because the one problem area, the challenging area, was with the San Jose Fire Department, and that directly affects my colleague on the committee's district in a way that's probably more relevant to her constituency than to mine. That all being said, Dr. Smith, my years are running together. I know you have the same problem, but I believe it was towards the end of 2013 when I looked down at the grid and said, hey, all of the various 7, 8, 9 first responders, however many there are or were at the time, are managing to meet their 90% on-time arrival requirements for incentive payments, with one exception, and that one exception was the San Jose Fire Department. Now, there were some politics in San Jose. That may be the understatement of the year, but there were some politics in San Jose around why that was, whose fault that was, and we weren't really concerned with that here. We were just trying to make sure that if you dialed 911 anywhere in the county, including in San Jose, that somebody would get to you on time with a 90% or plus expectation. And that was not happening in only one of the jurisdictions, and that was San Jose Fire. We've had a somewhat ambivalent back and forth policy at the board about to what extent did we want to sort of, I'll just say, look the other way. Some would say enable, some would say reward non-performance. Others would say, hey, let's not make a difficult situation worse by continuing to provide payments even when the performance wasn't there. And then for a while, we cut those payments off because they weren't being earned pursuant to the agreement. Then, at the behest of a board colleague, we started paying them again. Long history, long prologue. My question is, I know we were getting better results recently from San Jose. Have those better results continued since last we looked at them? So if I were to ask you for a chart for the last year with 12 months on it, what would it show us in terms of on-time performance?
For San Jose, they've made over 90% since April, the last 18 months.
Last 18 months. And that's every single month for 18 months?
Every single month.
All right. Well, then let's say congratulations and good wishes all around, because that was...
Would you like me to add the first responders as right below this?
Yes, please.
Yes, sir.
Okay. And I think, because for me, and you know, we've had some very helpful discussions in the committee over the years about the difference between the role the first responders play and the role that the ambulances play, and that not every 911 call is equal in terms of its significance or seriousness, and you know, getting all that. But this has been a crude but useful metric of, are folks getting there on a timely basis? And you know, for 2, 3, 4, 5 years, we had a situation where other providers were getting there, other first responders were getting there 97, 98, 99% of the time, and we just weren't getting it there. And I know the firefighters had their view about why that was, and city management had their view, and I just mostly wanted to make sure that people in San Jose could feel more confident, because it was thousands and thousands of calls given the size of San Jose. All right, if we could add that information going forward, that would be great. Pleased to see it. Could I get an off-agenda look at the last 18 months for the folks, and obviously shared with folks here who are our first responders, just to catch us up to date?
Last 18 months.
Sure, if that's what you've got. All right. Anything else on this item that you'd like to share, or that you have comments or questions about, Ms. Ellenberg?
No, the only additional was you had asked for on rate increase of the payers, and I only had charges up to this point.
Well, you know,
I am waiting for the contractor to actually get the actual, after they get a few bills and know what it is actually costing the constituents, so.
thank you. I am curious, and Dr. Smith, if you want to chime in here, please do. You know, my recollection is that the charge went up from something like, I don't know, what was it, $2,400 to $2,500, something like that?
It went from $2,461 to $2,553 for the actual charges. So it was a $91.88 increase, but it doesn't impact what they're actually paying. That's just
Yeah,
a
and
charge.
so then, is there a way to somewhat easily break out what does that mean in real life for a range of users, consumers? I mean, we've got folks who have full insurance, we've got folks who are on Medicaid, Medi-Cal, we've got folks who are on Medicare, we've got people who are out of pocket. I mean, I know that that number is not quote the real number, and I'm just trying to figure out what does this really mean in somebody's real life if they call 911 and the ambulance comes.
I will ask Rural Metro. I tasked them with giving me that information.
Great. Dr. Smith?
Just as a generality, it doesn't have much effect on the true consumer in the sense that individuals who are insured through Medi-Cal, Medicare, there's a fixed reimbursement from Medi-Cal, Medicare that's significantly less than what was mentioned. I think it's in the $250 range or something like that. And the provider is precluded from trying to extract any further payments from the patient. For individuals who are insured by other insurance companies, typically the insurance companies are the ones who take the risk. There are a few situations where there is the ability for Rural Metro to go back and try to recoup the difference between the insurance company payment and their charges, but the reality is they're very unlikely to succeed in that. And then for those individuals who are uninsured, the billing is never collected. So it's a relatively small effect on real people, but we're required to come up with a rate.
Got it. All right. Then going to look at staff. Does that complete this item in your judgment? It does. So then without objection, Supervisor Ellenberg, if we can get a motion to receive the report for item number 5, then I'll say without objection, hearing none, so ordered. Item number 5 is received. Thank you very much. Item number 6, receive reports previously requested by the committee relating to community clinics and hospital workforce integration. And why don't we just make sure that we break those down into 2 discrete chunks so that we talk about one first and then the other. So can we talk about community clinics first? Who wants to present on that?
Well, and good afternoon, Mr. Chair and Supervisor. As reported last month, but we also provide a little bit more information this month in terms of our current process with the community clinics. In the report, we indicate not only in terms of the total amounts that were granted to the community clinics as directed by the board, supervisors, as County Executive Jeff Smith and I and some of our staff met with each clinic to identify not only in terms of their experience, but also potential gaps. And as you recall, the Board of Supervisors approved a series of actions related to last fiscal year. So we give you a summary in terms both total as well as by clinic in terms of what we call the operating gap funding for 18-19. And then we also gave you a little bit of a summary of the changes in the contract for this fiscal year. They were agreed by the clinics. My understanding, pretty much everyone has signed that agreement except for 1 or 2 that have indicated they'll sign, but still in the process. We give you the totals in terms of the contracted amounts for this fiscal year, so that way you get a sense, not only compared to last year, but then also in terms of the contracted amounts for this year. The general agreement is that we'll maintain the performance-based model coming into this fiscal year, but with the understanding that we'll take a comprehensive review at mid-year, and we'll come back to our full board in terms of the status as part of the budget discussions that Dr. Smith will have with the Board of Supervisors. So with that, that concludes very briefly the report, and if you have any questions related to that process.
Thank you very much. Ms. Ellenberg.
Thank you. Thank you, Renee. I would like to invite, there's some folks here from the Community Health Partnerships, and I want to ask questions in both directions. So any of you who are interested in representing, I would love for you to come and just sit down in the front. Thank you. And I want to start by saying that I really appreciate the work of Dr. Smith, Renee, Dolores, and all of the clinics to come to agreement on both the FY19 and 20 contracts. And I really do think that this report reflects the collaborative effort that's taken place over the last several months. my first question that I want to ask in both directions is, do the revisions that are outlined in the report between the FY19 and FY20 contracts actually meet the needs of both HHS and the community clinics?
Definitely from our part, as you know, we're trying to address federal requirements that are embedded in the Line 15 waiver, which some of the funding streams allow us to expand care and services here in our community. So there's very little flexibility around some of those. But in our conversations with the community clinics, as you indicated, it's been very collaborative, very open process, and we try to accommodate based on their capacities, their own projections of who they can serve and the amounts of utilization they can project, and then obviously structure our contracts around those.
Thank you. And thoughts from this side?
Can you hear me? Oh, it's on. Okay.
And Raimundo, will you introduce yourself
My
for
name
the
is
record,
Raimundo
please?
Espinosa. I'm the CEO of Gardner Health Services, and I want to ditto what Mr. Santiago says. I think we're really appreciative of the conversation and the interaction, the collaboration that went on to resolve the issues last year and to create the new contracts this year. I think we went back and forth on some of the parameters, I think, which were a concern last year, and we adjusted those, and hopefully we'll be able to maximize the contracts this year through the efforts that we have. I'm speaking for, I know from myself as Gardner Health, the CEO of Gardner Health Services. I don't know if you want to add a little bit.
I'm Sarita Kohli, and I'm the CEO of Aki, and yeah, I would absolutely second that. I think there was a lot of openness from the department to work with us collaboratively, and we did some back and forth on what measures there would be for the performances and so on. And so, and the fact that we put in the contracts that there'll be a mid-year sort of relook at things was also a new thing, which was very helpful to us. I know that we do this in behavioral health all the time, so it's great to see it come across in this system as well. So it's been a helpful process, and thank you for your support, and to Dr. Smith and Renee for working so collaboratively with us.
Yeah, I'm Ken Graham. I'm president of the Mayview Community Health Center. Just reiterate that the process has gone a lot better this year. The efforts have been transparent and supportive. We've had significant attention at the highest levels of the county, so we appreciate their guidance and their support. Also, this is a really complicated set of processes. The payment systems are extremely complex and changing all the time. People turn over in the process, metrics change, and people have different demands from different sources, including insurance companies and government regulations. So I think the county staff's trying to do their best. We're trying to do our best, and overall the tone is constructive. Still not perfect, but it's getting better.
I'm glad to hear that. Sarita, you mentioned the process of the mid-year review. Are we on the same page with expectations as to what that will look like? Are you looking at individual planning sessions or working with the clinics as a group?
Yes, well, we're continuously to meet on a regular basis with the clinics because we recognize there has to be some process improvements that need to occur on data and billing and invoicing. What we're hoping to do is obviously by the mid-year we'll have at least hopefully 2 quarters of data and utilization as well as performance, and then be able to share that with each of the clinics, validate it, and then obviously provide the board with the full information.
And what do you anticipate the benchmarks in terms of performance or billing that will really inform that?
Well, I think it's going to be varied by clinics because some of the clinics are a little bit further along than others. So we anticipate some of the clinics to be able to be at or perhaps in some cases higher than the 50% that you would expect at the midpoint. I think some other clinics may not be at that 50% halfway point, but I think depending on where it's trending, in some cases they've had to hire new staff. In some cases they're doing some adjustments. So we'll get a better sense, obviously, in terms of not just the quantitative data, but also the qualitative information and give you a sense of where we stand.
Thank you. In the memo that was just provided by CHP, there's a reference to changes that should be implemented sooner than the mid-year review. Do any of you want to elaborate on that?
I'm not sure which health centers might require that type of assistance to look at it sooner than later. but I'm assuming that there are a couple of health centers that might want to start looking at it in November rather than waiting till the time that we had identified, till February.
Supervisor, could I chime in on this one without interrupting your train of thought?
Please.
Thank you. I'm a little bit flip, but I'm mostly serious. I've been through a lot of these conversations between our organization and the clinics. They're sometimes, shall we say, appreciably more strained than today's is. This is a veritable love fest compared to some of the conversations we've had. It strikes me, and again, I'm being a little bit flip, but mostly serious, that is in part a function of the fact that everybody sat down and talked with one another.
Yes.
So your question raises the follow-up, which is, so when is the next time everybody's going to be scheduled to sit down and talk with one another? And apparently I'm cribbing off my smarter classmate over here. And so literally the one thing I wrote down is, for God's sakes, for some reason we can't just have the clinics meeting with somebody in our organization once a month, because I just think if people would talk on a monthly basis, and just to be clear, I'm not saying it needs to be any one particular person. I know Mr. Santiago's got a list of meetings a mile long, same in our offices, but if somebody could just, I mean, Ms. Tully's, my recollection is you do that with, or somebody in your shop does that, I think it's you who does it with the providers, the contract providers in behavioral health, and I just think, it's not that they're always happy, they're not, they still have stuff, but it just seems like less of it gets sort of uncontrollably icky by virtue of those conversations. So I'm going to toss that out there, just let it sit for a minute and let my colleague carry on with their questions, but I didn't want to let that opportunity to make the pitch go by.
Thank you. I hadn't actually included the word icky, but otherwise.
Well, when you've been on this committee and acquired the professional expertise in layman's jargon that I have, you'll get there. So.
Yeah, I do share the same curiosity about next steps for strategic planning between the clinics and HHS. And Renee, it looked like you were going to lean in. I want to just add one more thought of something that I would really like to see, and then let you and the clinics go ahead and answer that. I think the piece that's still missing is that rather than year-to-year contract adjustments, I would really like to see more strategic thinking about our overall network of preventative and primary care resources that are inclusive of both VMC and community clinics. And it sounds like if we continue this process, we will get there, but I just want to call out that I think that will be a much more helpful and reliable model.
Right. No, we totally agree with you. I think on an operational level, there's obviously constant communications going back and forth. The formal meetings, I believe, are at least monthly with Michelle De La Calle, who's the director of the Office of System Integration. But her team communicates frequently and pretty much, I would say, weekly with the community clinics. And then, of course, on the strategic planning, as you know, we're running multiple parallel processes because as a system, we're doing our own internal strategic planning process. We're going to be launching the stakeholder process on October 1st. This is with the healthcare reform stakeholder group, and I presume that's going to lead us to a very focused strategic discussions with our community clinic partners. That'll be part of that process because this is all related to waiver and federal policy and what we anticipate and expect. So we can do that on a quarterly basis. We certainly we're at this point in time hoping as part of the mid-year to give you a full strategic planning update in February, March timeline.
Great. I will look forward to that. I hope the Love Fest continues. Please keep me updated, and I want to just extend appreciation once again to our clinic leaders that have come down here to speak today and to know and feel that you are valued partners in the county.
Thank you. Thank you. And I just want to say that Dolores would have been here, but she had a personal issue come up, but she wanted to be here to thank all of you as well. I know it's been a challenging at times process, but we're together. I mean, that's what we believe, and we're part of the system the system of care in this county, and we want to do the best that we can, and also survive in the process. So that's what we're trying to do. Thank you.
So before you step away, I want to stay on this issue of a monthly meeting, because I hear that there are lots of conversations, but it wasn't entirely clear to me that there is a regular meeting at which you sit down and thrash out these contract issues. So whoever's channeling Dolores Alvarado, do such meetings happen on a monthly basis or not?
I'm not with the whole group. The last meeting I think that we had were the individual meetings with Dr. Smith, and then individual meetings with Alice, who was organizing with the contracts. But we have not had a meeting since then, unless Dolores has had a meeting with Michelle DeCalle on a monthly basis, but I'm not aware of.
Yeah,
us
ordinarily, I
having
wouldn't micromanage something like this, but I feel like too often, too much stuff bubbles up that could and should be handled there. Dr. Smith, what are you thinking?
Yeah, I think we'll schedule some monthly meetings, and we'll start off with Renee and myself meeting on a monthly basis.
And again, I know your time is limited. I mean, everybody's time is valuable, and everybody's time is limited. So you'll be the best judge of whether you need to be in the room, somebody else can be in the room on your behalf. But I just, I know from the experience at behavioral health and from the good experience that you have when you do get the chance to sit down, and I know in my own office the things that we, talk about regularly rarely suddenly go off the rails. The things that we think, we'll just get to it when we need to, all of a sudden we need to, and it's not for a good reason. So I appreciate that offer, and I'm going to ask you to give us an off-agenda report that tells us what that looks like and when it's scheduled for, if that's agreeable. I see my colleague leaning in.
I just want to clarify, when you said that you and Renee will meet monthly, you mean you and
With
Renee
them.
will meet monthly with a group of
Right.
CHP?
Yeah.
Well, no, we don't want to meet. We don't want to meet with them, no. Yeah,
it all
Renee
on
and
the
I
record.
will
Thank
meet
you.
monthly with the clinics.
Yeah.
And then we'll decide, when we meet monthly, if the individual clinics have additional issues, we'll meet with them also in addition individually.
Last time, I'm going to give you a bit of an escape clause. It's an $8 billion a year operation with 22,000 people and 2 million constituents. You can't meet with everybody all the time. So I'm really mindful of that and respectful of it. And Dr. Smith, I know how much time you spend meeting with just our board members, so I don't, it's really helpful time, but I know you have an organization to manage, so I just want to be respectful of that even as I make the ask. Thank you. All right.
Noted and appreciated.
Thank you. Then we'll,
Yeah, so before we leave, the only other issue I think was just that.
are you going to Columbo us today? Is that what you're going to do? One more thing? Is that what's
something on the indemnity clause? I
Yeah,
think was an
thank
issue,
you.
And
How's that working out? That's my question.
we're waiting.
Okay.
So that's-
Let me turn to staff. How's that working out?
We're still arm wrestling about it, and we'll be discussing it at our first meeting.
If somebody were to try and explain to one of my constituents at sidewalk office hours, what's this tension about? And it's a healthy and legitimate tension. What's this tension about? Should I look down to Mr. Coelho, who is from county counsel's office, or is this about who is indemnifying who for what, and whether or not the expectation of indemnification is a reasonable one? Is that sort of to grossly overgeneralize it?
Yeah, that's sort of the basics. I don't know if Rob's totally up to date with it. If he is, he can jump in and correct me. If not, I'll try to give a basic assessment. The question is, we basically have a sort of four-party issue with regard to insurance for malpractice issues. One is the county, one is the clinic entity, which oftentimes is a nonprofit structure. I should say always is a nonprofit structure. One is the regulatory requirements from the state and the feds, mostly the feds, and the other is whatever insurance company has been already hired by the clinics, and trying to apportion the responsibilities in a rational way that protects the county and the clinics has been a challenge. And so we've been working with county council to come up with what we think would be a solution for everybody. And I'll probably just leave it at that. I think, we'll work through it and get it done, but with lots of people and lots of opinions, it's challenging.
Yeah, and I just want to say to the clinics, I actually remember dealing with this issue in an unfortunate way 20 years ago on the behavioral health side, which was we had a raft of contracts that came to our board for approval, and candidly, we were struggling in the county counsel's office at the time, and I flipped through the contracts before the board meeting and had to ask at the board meeting, and excuse me, I don't see any indemnification clause in any of the contracts with any of the 20 community-based mental health providers. And as you can imagine, that brought the conversation to a bit of a thud, because everybody was sort of contemplating, well, what does it mean if the county is on the hook for the potentially negligent actions of 20 different providers out doing their own thing? And of course, everybody understood that wasn't something that was going to work for the county. So they immediately said, we'll get back to you on that, and came back with an indemnification clause that did work. To grossly oversimplify and to stay out of the back and forth with our legal folks, we need to make sure that you all are responsible for your conduct, just as I'm sure you're sitting there saying, yes, and we need to make sure we're not responsible for your conduct, and that we're only responsible for our conduct. And as Dr. Smith tried to say 10 minutes ago, we look forward to a happy outcome in that conversation. Okay?
Thank you.
Yeah, that's the essence.
Okay? I'm even getting a little shout out from somebody
Okay,
down
thank
there
you.
on that, so okay. Thank you very much.
All right, thanks.
Anything else on this item? If not, we will move on to the other half of this item, which is the issue of the hospital integration, particularly around workforce issues. And at the risk of stating the obvious, we've had big challenge on our hands with the acquisition of a couple new hospitals and integrating their workforce into our own. And we have certainly heard a lot from folks about the workforce integration challenges. And so it seemed healthy and appropriate to put the item down here and say, where we've been, how we doing, where we headed, and what are the prospects for the future. That's my gross oversimplification. I see lights on from both Mr. Marquez and Mr. Lorenz. Mr. Lorenz is deferring to Mr. Marquez, and then we have someone else with us here as well to report. Mr. Marquez, why don't you lead us off?
Thank you, Supervisor. So let me start by just letting you know that John Mills, Director of the Employee Services Agency, is in Los Angeles today for a pre-planned event or other conference that he's attending, so he can't be here. We do have Dave Manson available, who leads the ESA's efforts for the hospitals and clinics, so he's here to provide updated information and anything else. But overall, there was part of the report that's in the agenda has some narrative about the integration efforts, and then the supplemental report was issued yesterday in response to Supervisor Ellenberg's question yesterday. But in essence, there are 1,514 employees at both O'Connor and St. Louis when you combine them. But of those, 373 are extra help. So that leaves us about 1,126 either provisional or probationary employees. And then I think an important figure on the timeline to look at is figure 7, which shows us where we are today. And it shows that of those 1,125 people, 777 of them are in recruitment now, and 347 are left yet to be recruited. But the timeline shows by the end of mid-December, we'll have all 1,124 through recruitment down to 0 left pending to go through that process. So the goal there is to move everyone from provisional to probationary, and that's on a timeline that should end by mid-December. And then finally, just to add to some of the complexity of the task at hand, the memo from yesterday talks about the classification studies that are underway. There are 46 currently undertaken, and there's a list in that supplemental memo of what those 46 are. Just to highlight, there are some priorities among those 46. The 2 prioritized are the health services representative and the diagnostic imaging technicians. The memo, I won't go through it, but details the lengthy process that it takes relative to any number of stakeholders to go through the classification study. And at the end, there's a process that involves the unions to sort of meet with them and obtain concurrence. So it's hard to pinpoint an exact timeline on those classification studies being completed, but they are moving forward as quickly as possible with, of course, the prioritization on the 2 classifications that I mentioned. And I think, and let me just turn it over now to Mr. Manson to see if he might have some additional updated information in real time that you can share with the committee.
Dave Manson, Employee Services Agency. The update that I have is we provided updated information on the number of employees that had moved from probationary status into provisional status in Figure 4 and 5 of your packet. In doing some more in-depth research in this week, we have found that 351 clinical nurses total have moved into probationary status. That leaves 91 that we're projecting will move into probationary status October 7th, the beginning of the next pay period. That will conclude at that point all of the clinical nurses that were provisional into probationary status with the county.
I'm pretty sure I know the answer to this question, but I just want to make sure. Would you remind us what the difference between provisional and probationary is, for those to whom that's not a readily apparent distinction?
Certainly. Provisional is a temporary status where we put individuals in pending the recruitment of their coded position. When they are recruited from from provisional status into probationary, they are a fully coded county employee, and they are on probation for the amount of time that their union contract dictates they're on probation. It's no longer in a temporary status.
Thank you.
Although, Supervisor, if I may add, and please correct me if I'm wrong, and I think this is a point of just the verbiage sometimes not matching. When they're placed provisionally, the board already created permanent coded positions, and they're placed provisionally in that permanent coded position. So it's a provisional placement in a permanent position, after which they'll go through a process and become probationary for a period of time, after which they become permanent in that permanent code. But the code is theirs even as a provisional employee. Please correct me if I'm wrong.
Correct.
Okay. Thank you. I hope that was clear.
No, it is. I'm sure it's rare that I speak for another colleague, but I'm sure Supervisor Ellenberg are both having similar conversations with folks in the organization who are anxious about their status. And, you know, these distinctions are not always entirely clear based on the HR jargon that is attached to them. I don't mean that disparagingly. Every industry has its term of arts. But it's why I asked to get, you know, a specific reminder about the distinction between one and the other, because, you know, we got a lot of people who, you know, if you're not familiar with these distinctions, you think, well, gee, you're in the job. What's the anxiety about? And the distinction between the 2 or 3 different levels that you've described, I think does help clarify why people may be anxious, even though they're, quote, in the job, based on their category or categorization. So, Supervisor Ellenberg, I see your light is on.
It is confusing. I will start with that. The report that was submitted indicates that all eligibility lists should be delivered to the hiring managers by mid-January. That's still correct? So I'm concerned that that's cutting it too close to the end of this phase to allow hiring managers to complete recruitments and work with employees that may not make the eligibility lists or be selected with enough time to resolve their individual questions. I'm wondering if we can aim instead to provide the eligibility list to all managers to allow for that standard 90-day hire before the February 28th deadline. That would put us at the start of December.
We'd have to take a look at each of those recruitments as they're planned out and see if that's a possibility.
Okay. Also in the report posted yesterday, the health services rep and diagnostic imaging tech positions are noted as classification studies to be completed prior to recruitment. Do you know about how many employees are in each of these classifications, and when do you expect the studies to be completed?
I don't know the number of employees right off the top of my head. The Health Services Representative Classification Study is in review, HR review now. It will be going to the department and then to the union probably in the next 2 to 3 weeks at the latest. The Diagnostic Imaging Tech Classification Study has just begun about a week ago.
And the timing?
It's going to take about 3 weeks or so to get it into the process so that it can go back to the department for review and then back to the union as is outlined in that memo that John Mills sent.
Did you tell me, I'm sorry, did I just miss, did you tell me about how many employees we're talking about?
I
in these
don't know
groups?
that right off the top of my head.
Okay, could you send that information
Certainly
to us
can.
off agenda? Thank you. It's also my understanding that employees in the newly created unclassified positions that we just approved will have 18 months from their unclassified date of hire to convert to a regular position. I have a couple questions about this. First, what resources will be provided to help them with that transition?
I'm not sure I understand the question. For the employees?
Yes, to support them. Obviously, we want them ultimately to pass whatever tests they need to pass to stay in their jobs. Will we be providing support to help them get
Right,
to
my
a
understanding,
place?
ESA is working closely with the Learning Employee Development and the unions to provide some test-taking classes and materials to provide them some support in taking the test subsequent to being in the unclassified codes.
And if there are more employees who have not yet taken the test or have not yet gotten their results, if they find themselves in that same circumstance, will we expand that unclassified group, or is it capped?
It's my understanding that, although we can't anticipate the numbers, my understanding that as employees unfortunately fail the exam, that we'll be coming back to the board to create unclassified positions for them.
Okay, so that number is expandable. I think that's an important piece to convey because there's a lot of confusion about whether the group that's already falling within that distinction is the only people that will get that benefit.
Right. To my understanding, it will be expanded as, unfortunately, people fail the exams.
Terrific. To help us keep track of this process, I would like the HHC pending board items report to include the ESA items on hospital staff integration, starting with the October report. Can we do that? Okay, that is all I have. Thank you very much. Thanks, Dave.
Thank you. It's Mr. Manson, yes. My recollection is that we were hoping to clear all of the provisionals and move them into probationary status by March. Am I remembering that right?
That is correct. Provisional status is allowable up to 1 year. So March 1st of 2020 would be 1 year for these provisional employees. So they would have to be moved out of provisional status into another status prior to 3/1/2020.
Thank you. That was actually a very helpful and very clear explanation. But I'm smiling because that doesn't necessarily mean everybody will move from provisional to probationary, because some people will not make it into probationary. Is that that's right?
That's a possibility, yes, sir.
Okay. And that push comes to shove date you're reminding us is really March 1st of 2020, yeah?
That's correct.
Okay. And then my recollection is that we had, oh gosh, something 80+% of our grievances that were resolved, 82, 83, something like that. But that, of course, means that something like 15 to 20% weren't resolved. What's the status of those? And the reason I'm asking is, understand, again, everybody's doing the best they can, but the longer those things linger, they sort of fester and create some more ickiness in the system. So what's the status of the unresolved grievances?
We are continuing to resolve all of those issues till we get to 100%. There'll be another report, I think, at the next board meeting, at the next HHC, with that updated information.
Is the number going down?
It's definitely going down.
Okay, so we're not getting so many new ones that the number's going up while we're getting rid of some of the old ones?
That's correct.
Okay,
Any new issues that we're getting, issues and concerns are being dealt with immediately with the staff that we have. And we have other staff that are working on the backlog of the 85% that are resolved.
Great. And then going back to the questions and answers that were generated from Ms. Ellenberg's questions, so we had some folks who took a test, couldn't make it past the test. Some of those folks were able to stay on the job by virtue of a classified position, yes?
Unclassified, yes, sir.
Unclassified position, excuse me. And many, if not all, those folks were in the what would be commonly referred to as custodial ranks, yes?
Correct.
But there are other folks who are going to be taking tests or have been taking tests who also unfortunately aren't able to pass the test. Am I right about that?
Most likely.
And are those unclassified, excuse me, Plan B finesse routes available to them as well, or is that only for folks in those classes?
Perhaps I could jump in. This is
jump away.
So, you know, we've talked
Mr.
about...
Manson, you were looking like you were hoping somebody would jump in, so you got a little phone a friend here. That's good.
You know, the onboarding of these 1,500 employees was complicated, and we have a lot of internal rules that we must follow, merit system rules and the ordinances and everything else. It didn't, as we know, for the custodial staff and some others, the process that we laid forth didn't work for them, and so we've been problem solving, and we came up with largely a scheme of unclassified for up to 12 months, 18 months, up to 18 months, and we're going to have learning and employee development work with them to try and get them prepared and support. To the extent we continue to find more problems as we continue to integrate, I think rather than commit now to a particular course, it might not be the course that makes sense at the time. I can certainly commit that we will do our best to problem solve, so we're compliant with the rules, but we reach the goal of having those employees who were brought on be able to join our workforce.
And one of the rare times you'll get me to say this, I don't have an opinion about whether or not that's a useful tool in other venues. I really am just asking the question today to make sure I understand. It sounds to me as if you're saying, to date, thus far, so far, that creative solution, which I think we all applauded, has been limited to folks in the custodial roles.
Has been applied to them so far only that I'm aware of. But as issues arise, that's certainly going to be something we'll look to see if that works for other classifications or if there might be a different and better way to solve the problem. But I think what we're committed to is to solving the problem.
Got it. No, thank you. As I said, as we go through our work, I want to make sure I understand how we're actually handling various, very different classifications. Thank you, Mr. Manson. That, I think, Supervisor Ellenberg takes care of both items under item number 6. Any additional comments or questions from you? Let me just confirm. Don't believe we have any cards or questions. Nope. Then we have a motion to receive the report from Supervisor Ellenberg, and without objection, hearing none, so ordered. We're good to go. That takes us to item number 7, and that, of course, is our multi-layered director's report. And let's start with 7A.
Yes, and just to be mindful of time, the only thing I would offer is that if there were several bills that were passed by the state legislature, and we have a summary of those that we were tracking and monitoring, if there's any particular ones, or if you want us to invite our lobbyists, state lobbyists, to give you a full update in terms of not only what the legislature passed, but also what the governor signed, we could certainly invite Kelly Brooks to the next Health and Hospital Committee, and that way you have a full detailed account in terms of what was passed by the state of California.
Why don't we follow up with my staff on that, and we'll explore the possibility and see if we can make that work with other items on the calendar, but we'll follow up on that. Thanks.
That concludes my report.
Okay. How about from the health officer? And let me just say, I know Sarah Cody, and you're no Sarah Cody, so
I am
welcome.
not. Thank
Welcome.
you.
Truly.
Good afternoon. I'm Dr. George Hahn, Deputy Health Officer, filling in for Dr. Cody, who's attending the California Health Officers meeting and can't be here today. I do have 3 updates for you and am happy to answer any questions as best as I can.
Thank you, Doctor.
Yesterday, we publicly announced 2 influenza deaths in our county, 1 in an adult and 1 in a child. And this is a bit unusual for us. We don't usually see flu deaths until we're already well into the flu season. Interestingly, we have not been seeing other indicators of much flu activity. We do know that the adult case had not traveled in and thus had acquired the infection here. In contrast, the pediatric case likely acquired the infection overseas. These cases highlight the need for flu shots, and we do recommend them for everyone age 6 months and older, and for taking a flu shot before international travel.
Doc, excuse me, before you go forward with the next item, Dr. Cody and I have this conversation every year. I rely on her to prompt me when it's time for the flu shot. One of the conversations we have is what time of year is it time yet for this season? So if I ask you the question, is it time yet for this season? The answer is?
Yes.
There you go. Thank you. On to the next item.
Second, I want to share that we're working very closely with the Office of the District Attorney, the Medical Examiner, and Behavioral Health to ensure that both healthcare providers and educators are aware that pills made to look like oxycodone but actually containing lethal doses of fentanyl are circulating in our county and have caused several deaths. We sent a health advisory to providers and a separate one to schools and other organizations that work with teenagers and young adults. We are getting ready to send out an addendum in multiple languages that includes information on how to access and use Narcan. The bottom line is that we want to make sure that people are aware that these fake pills are in our community, and we hope that getting the word out will prevent more deaths.
And who is the primary target for this product? Is it young? You mentioned young people in specific, I noticed. Is that?
I think anyone who might be taking oxycodone is at risk, and that does include young people.
Got it.
And finally, I wanted to provide a short update on vaping and note that Nicole Cox from our tobacco program is here to field any questions that you may have. We have received a report of one probable case of acute lung injury associated with vaping and expect that we may receive more. In California, as of yesterday, there have been at least 90 cases reported with 2 deaths, and nationwide, as of September 19th, there have been at least 530 cases reported with 7 deaths.
Thank you. And as I suspect you know, we had some conversation about this at yesterday's board meeting. Anticipate having an item come back to our board on November the 5th, but come through this committee en route on October the 30th, if I remember my dates correctly. And that is in part to make sure that at least 2 members of the board have an opportunity to both raise issues that will inform, hopefully, the conversation on the 5th in front of the full board, and also get questions asked and answered so that we can deal with the issue expeditiously on the 5th. Comments or questions before I turn to the next reporter, Supervisor?
Yeah, just a quick question, and you said Nicole is here, who might be the better one to, hello there, to answer it. The report mentions the upcoming release of funding for youth and community groups for engagement, education, and capacity building on tobacco prevention. Can you talk about the primary strategies and populations for this effort?
Yeah, I'd be happy to. So we have 3 categories of funding that we'll be releasing. One category of funding is called the Community Action Model Grants, and those are larger scale grants of up to $200,000 apiece over a 2-year period, where agencies can work deeply within a neighborhood or city on strategies that will impact long-term solutions. So many of the policy types of actions that have occurred at the county level, so that we can have those same impacts across many of our city jurisdictions. And in terms of the populations or neighborhoods of focus, really looking at those communities where there's more concentration of tobacco outlets, where there are higher rates of tobacco use, namely our Asian men in the community, Vietnamese, Filipino, Pacific Islander men, the LGBTQ populations, youth, of course, are targets of tobacco industry marketing. So that is our plan, and we aim to release that RFP in early October.
And will this overlap, or can this funding also be used to focus on e-cigarette use and other vaping? So it's not limited to just regular cigarettes.
Right. I should clarify, when I use the term tobacco, I include e-cigarettes in that category, but absolutely that would be our primary focus as well.
Great. I'll look forward to learning what what the specific details of those are. Thank you.
Thank you. And before you step away, I'll underscore, It's a thought I've had before, but it was Supervisor Chavez's comment at yesterday's board meeting that made me think it yet again. She made the, I thought, very good point that as we struggle to communicate and deter unhealthy behaviors, we have to find messages and methods that are going to reach the target audience, and that, you know, we may have a group of younger people, younger adults who we're talking to who sort of are already of the mindset that this is not something they do, and if all we're doing is talking to folks who don't need persuading, we're not actually making progress. So there's a harder to reach population, and we got to figure out how to reach that harder to reach population with an effective message. And I've seen some efforts that were pretty feeble, not from this organization. It's just I think it's a marketing struggle. So I hope we'll sort of just face that down and do the best we can, mindful of the fact that it's a different challenge. Thank you so much.
Thank you.
Then that would take us to 7D, behavioral health. Ms. Tullies, are you going to lean in on this one? Once you find a microphone that works.
I always have problems. Is it on now?
Well, Ms. Tullies, don't worry about it, because apparently I was just cruising right by 7C, the CEO. So why don't I go to the CEO of the Valley Medical
I
Center?
have it on, but let's
Oh,
go to
well,
the
we'll go to
CEO.
the, so, no,
Do you want me to continue? Would you
sure,
like me
why
to?
not? I think Mr. Lorenz can hang in there for another 2 minutes.
We have a brief report this particular moment about launching the MHSA, what we're doing with the Contractor Association. We had a very positive meeting with all the contractors yesterday in the Sobering Center. I know you're particularly interested in all of the new services, and will they be standing up in October? And I will go on the public record that yes, they will be. Are there other questions that you would like to ask me, Supervisor?
Yes, there are, Ms. Tullies.
Okay.
How's that lease on the formerly known as Headspace, now known as lowercase a double L Alcove
Yes.
facility in Palo Alto, California?
Yes, and that particular lease will be coming to the board according to Fleet and Facility on, let me look up my date, I have all the info here, 10/22. Yesterday was the San Jose site lease, and I know that that was put on consent, and that there's been ongoing conversations with the Palo Alto site lease, and they do expect that it will be in a couple more weeks.
Does ongoing conversations, it sounds suspiciously like a euphemism for they still haven't signed the lease on the other end.
I think it's on the Palo Alto side, sir.
Yeah. Can I ask you and the county counsel's office to please check the status of that and give us an off-agenda report before close of business on Friday this week, please? Because the 22nd is, you know, would be a celebratory day, but it would be, as you know, a celebratory day that took a lot of work, and thank you again.
Yes.
But if it slipped past the 22nd, that would make the celebration not happen, and we don't want that to happen.
And neither do we, Supervisor.
Great,
So,
good.
yes.
So, and delighted to hear and congratulations that we're going to roll out some very important programs in October as planned. I won't belabor that point.
I want to just
Please.
belabor it for a quick second. Is there, I'm thrilled about this, first of all, and thank you. Is there a PR or marketing or somehow outwardly visible announcement of these services so that folks will know what the county is doing differently now?
My office and I are in touch with Ms. Tully's already about that and her outreach staff. And if you'd like to be included in the outreach, we'd love to include you in that way, Supervisor.
I have been working with Joy Alexio, the health PIO, and her recommendation was let's get things out and know that we have the services and then do a big piece. So I'll certainly work with your offices on this. We're
Thank you
very
very much.
excited about
Great.
all the work that's underway.
Thank you again.
You are welcome.
Now, 7C, which in committee parlance follows 7D apparently. So go right ahead, Mr. Lorenz.
Thank you, Supervisor Samiti. And so, of course, you have the written report. I just want to add and share with the committee here and the two of you that it's been 5 weeks since we've implemented the enterprise-wide EHR. It's gone remarkably well, given the short time frame in which we implemented the system. A lot of credit should go to, of course, TSS and the HealthLink team, but keep in mind, it takes providers, the physicians, the nurses, the staff to utilize the system, and they've adjusted, again, remarkably well. We're in the process of optimizing the system, making sure that we're using it to its full extent around workflows and processes and clinical care. We're looking to, as John has mentioned and provided in his report, optimize our revenue cycle to ensure that we're capturing all the charges that we're providing in terms of care. And we are looking now to further our efforts around the data and analytics to ensure that we're watching how the system is performing, but looking for opportunities for improvement across the system. So I'm very excited about that, and I know the team is very excited about the opportunities that this system will afford us. I do want to thank you and the board for investing in this. This is foundational to the success of those two hospitals and to the entire delivery system. We are also in the process of preparing for an extended accreditation process. This is the time in which a joint commission will come in to ensure that we are meeting certain standards relative to the system. Today, we have the laboratory under review from the Joint Commission. That is going very well. And again, I want to thank the staff for looking at this from an enterprise-wide perspective in terms of maintaining a certain level and standard of care that we need to afford our community. And finally, September 30th brings us to a point in which the transitional services agreement with Verity will end. We are working very closely with procurement, county council, and TSS to ensure that we meet that deadline and that we can release any further relationship with Verity and move forward as an organization. So that's another milestone, I would say probably the last milestone in terms of our relationship with the Verity organization. And so I wanted to share that with you. And with that being said, I'm happy to answer any questions that you may have.
Supervisor Ellenberg. Electronic health records? Privacy, privacy, privacy. I'm going to keep pushing on that issue, particularly as we're bringing two new organizations into our organization to create one unified organization. You know, culture's different, experience is different, history's different. I have no notion how much the commitment was or wasn't in place to patient privacy in the other two organizations, but I just want to ask again that you know, beyond our legal requirements with HIPAA, we're sensitive to. I mean, they're just. I'm always surprised, frankly, that there hasn't been more discussion. I know there's some about the potential for abuse, misuse around access, and you know, the 21st century marvel that is electronic health records has an extraordinary benefit, in my judgment, and an unrealized benefit in terms of quality care. But it also has a substantial risk, if misused, around privacy. And just want to make sure that stays top of mind. And so if I am sounding like what apparently Joe Biden would call a broken record, then that's why. Okay?
Completely understood.
Thanks. All right, how about 7E, the health plan? What's going on?
Good afternoon. I'm Deborah Halliday, Interim CEO. I will take any questions that you might have on the report that was submitted, but in the absence of those, I'd like to make a few comments about open enrollment for Cover California and what you should anticipate seeing in the community. So as everybody knows, open enrollment starts October 1st. It's an exciting event for us, and we've taken a much different approach than we've taken in the past to market at events. Thanks to you, we are out in the community in a way that we haven't been before. We've also conducted focus groups, and we've identified, not surprisingly, that the VHP brand is not well known in quite a number of our communities that we serve. So we're doing what's called brand lending. We're taking the brand of other well-known organizations in the community and partnering with them to support our efforts to get out and bring forth the message of the importance of health coverage and the importance of prevention and other things. So we're partnering, as you know, with the Earthquakes and Univision. We have a unique partnership with them where they're actually retweeting and putting on their Facebook page some town hall meetings that we're doing. We're really targeting the Vietnamese and Hispanic population. And so I just wanted to make that known to all of you, and we look forward to having a successful open enrollment. We're targeting about 7% additional growth in that product, which would bring us, we are currently at 16,800 effectuated members, so we anticipate about 7% growth through these efforts. We also have a number of new commercials that you'll be seeing. And our slogan, which I actually love, is because we live here. So we're really highlighting the uniqueness of VHP as being local and have a unique understanding and ability to intervene with the populations that we serve. Part of our success, we think, this time will also be as a result of the expansion of the provider network, as a result of the 2 hospitals that were acquired. We've actively, as you know, been in the market recruiting additional physicians to provide services to the covered California population. So I hope you'll join us in getting the word out about VHP, and I'm happy to take any questions that you might have.
Supervisor Ellenberg? And the open enrollment period closes?
In January.
Okay. And I used to know, but I have forgotten, the bulk of your activity, as I recall, peaks at a particular time, and that is when?
We will be doing open enrollment activities in the community through that entire time.
But is there a surge in terms of when you get the most folks?
At the end.
At the end, just,
yes,
okay.
Absolutely. People make the decision at the last minute.
Got it. Okay. Then we'll move on to the next item on item number 7, and that would be the verbal report relating to the federal health policy and budget landscape. And Mr. Santiago, can I turn to Mr. Margolin for that?
Barry Margolin is here to give us the latest update.
Thank you. Mr. Margolin?
Yes. When I reported last month, I talked about bipartisanship in the budget process, a desire by both Republicans and Democrats to avoid a government shutdown, and where possible in areas like drug pricing and surprise billing reach bipartisan agreement. With the historic decision yesterday by Speaker Pelosi to launch an impeachment inquiry, we've entered uncharted territory, and prior analysis and predictions don't mean very much. The wild card is obviously going to be the president's reaction. He might be less likely to want to negotiate with Democrats and probably more open to a high-profile clash with them over the budget, but there's no way to know for sure. When Presidents Nixon and Clinton were facing similar circumstances, they did in fact negotiate these kinds of issues, notwithstanding an impeachment process, but President Trump has his own model for how to conduct the presidency, and we can't predict what he'll do. On the budget update itself, the House has passed a continuing resolution which keeps funding and programs going through November 21. We expect that either today or tomorrow, the Senate will also act on the CR, and notwithstanding, again, this impeachment issue, the president is very likely to sign the continuing resolution. The real crunch on the budget is likely to occur in around or near November 21 when this CR expires. We've also been tracking the disproportionate share hospital funding cut, the DSH cut that was prescribed by the passage of the ACA. This cut has been deferred several times. There's a $30 million impact on Santa Clara County in year one if the cut goes forward. House Energy and Commerce Committee has passed a bill that cancels the cut for the upcoming year and the year after. The Senate has not acted yet. Again, there is bipartisan agreement. This reduction in DISH funding should be deferred, but we're not there yet in terms of an agreement. On prescription drug pricing, Speaker Pelosi has unveiled her bill early this week. In fact, today, the House Energy and Commerce Subcommittee, chaired by Congresswoman Eshoo, had the first hearing on the Pelosi bill. Her bill would allow Health and Human Services to negotiate prices directly with drug companies on a minimum of 25 drugs and a maximum of 250. These negotiated prices would apply not just to Medicare, but to other purchasers as well. The Progressive Caucus has not been very happy with Speaker Pelosi's offer. The minimum of 25 they think is too low. They want to see 250 drugs or more applied to this program. So there's going to be still a continuing internal negotiation among Democrats. As far as the president and the Republicans are concerned, there is major confusion on this issue. The president has tweeted positive comments about the Pelosi bill prior to this impeachment inquiry. Senate leadership, however, has been very hostile. Senator McConnell has referred to Pelosi's approach as socialist price controls. In the Senate, Senator Grassley has been the lead negotiator. He has not been for direct negotiation. He instead has been for a cap on annual price increases linked to inflation. But even that much more modest proposal has significant Republican opposition who view it as an interference in the marketplace. So in the midst of all this, with McConnell on one end, Grassley in another place, Pelosi in a third place, everyone's been looking for the president to provide clarity. That hasn't happened yet, so we're still adrift when it comes to drug pricing. Surprise billing was supposed to be low-hanging fruit. We've talked about how that's an issue that we thought would be dealt with this year because, again, there's this bipartisan consensus that if you go to a hospital ER, you shouldn't, as a consumer, be hit with an unexpected bill from out-of-network providers. The House Energy and Commerce Committee has already passed a bill to address this issue. But what's made that issue even more uncertain going forward is a substantial increase in opposition that surfaced in the last several weeks, funded by private equity firms who have purchased physician practices and purchased those practices based upon the concept of billings that require surprise billing to be part of the mix. They funded a multi-million-dollar negative campaign on this issue. There are other providers who independently have concerns about the formula used, so that's also up in the air. On the regulation front, there are two big issues we are following. The Title X rule, the gag rule on abortion counseling or services, is in effect. It's being challenged in the Ninth Circuit. A hearing on whether or not to impose an injunction was held earlier this week. We're still waiting for a decision. Planned Parenthood affiliates, as the board already knows, have long since pulled out of the program. But again, there's this litigation going forward to try to get the new rule stopped. The public charge rule is out and takes effect October 15th. The big danger here, which is already being felt by health providers around the country, is the fear factor that immigrants, even though they probably are not technically going to be affected by public charge given their circumstances, the fear factor is keeping them out of the healthcare system, out of the Medicaid system. To add to the fear factor, the Trump administration is planning to add a second rule to the mix in mid-October. It's related to public charge, and it addresses criteria for deportation based on public charge status. Now, this rule has the scary word deportation in it. It will actually, we haven't seen it yet, but it's probably going to apply to a very, very small population of immigrants. But by putting this rule out, by linking it to public charge, and by using the term deportation, the fear factor, the anxiety will be enhanced. We're still waiting on the Fifth Circuit decision on the Texas versus U.S. case, the one that would overturn the Affordable Care Act. Oral arguments were completed in July. Appellate panel is reviewing. Opinion could come at any time. Hasn't happened yet. We have a Medicaid waiver negotiation that's going to start soon in earnest. It's very critical for Santa Clara County and all public health systems in California. The state is actually combining this waiver negotiation with a broader planning effort they are calling CalAIM. CalAIM will be a multi-year effort to accomplish a series of things to make, from the state's perspective, the Medicaid system less complex. They want to reduce variation and complexity across delivery systems. They want to also promote value-based initiatives and payment reform. They are creating multiple work groups with stakeholders. Santa Clara County will hopefully be part of those work groups. They've certainly applied to be. That will focus on a range of issues involving quality and simplicity. And these work groups will soon be announced. The next stakeholder advisory committee meeting, which will address CalAIM and the Medicaid waiver, will be held on October 29th. And the state says they will release at that time, on October 29th, their overview of what CalAIM is attempting to accomplish, as well as their concepts for waiver renewal. So that will be a very important meeting that we will discuss at your next session of this committee. Final item worth mentioning just quickly is the new U.S. Census data on the uninsured. The bad news in that data, which came out earlier this month, is that it represented the first uptick in lack of insurance since the ACA was passed. The national number went from 7.9% to 8.5%. It's gone down every year since the ACA was passed before this last year. So that's bad news, but again, not catastrophic. It's not an evidence that the ACA is imploding. It is evidence that the administration's efforts to restrict marketing, to restrict various other aspects of the program at an administrative level have had an effect. The good news in all this, somewhat good news, is that for California, the uninsured rate stayed level. We were at 7.2%. We're still at 7.2%. So the rest of the country has an uptick. We're not experiencing that, and that's evidence that commitment by the state and by counties like Santa Clara to resisting this effort to erode the Affordable Care Act has had an effect. I mean, we're holding our own here in California.
Excuse the interruption.
Yes,
and here in
it.
Santa Clara County, our uninsured rate is lower than the 7% and change. And I just wanted to insert that into the record
Yes.
before we went on.
Yes, even better here in Santa Clara County, and worth noting. So that's my final point. Evidence, again, that if a state and a county are proactive, they can resist this national trend. That completes the report. Happy to respond to questions.
Thank you. I want to go back to the drug pricing issue.
Sure.
A couple of questions there. You mentioned well, earlier in the year, we were focusing to some extent on differences within the Democratic caucus between the more aggressive approach that Mr. Doggett wanted to take, if I remember
Yes.
correctly, and Ms. Pelosi and Ms. Eshoo wanted to take. And I didn't hear you mention Mr. Doggett's name, and it sounds like folks are sort of setting their sights on something that they feel may be more modest but achievable. Did I draw the right inference, or is there something else that didn't get mentioned?
No, I probably went over that too quickly.
Okay.
And I don't have information about Mr. Doggett specifically, but the Progressive Caucus, which supported Mr. Doggett's effort to require Health and Human Services to negotiate for all drugs, not 25, not 250, all drugs. That was the initial position, and I'm sure the continuing preference of that group. They pushed Speaker Pelosi from a position of not wanting to see that kind of direct negotiation. She had a much more modest concept originally involving arbitration. Now there's a negotiation provision in her bill, but what they're unhappy about, and this may include Mr. Doggett, but certainly people who support his bill have this concern, is that instead of they were willing to maybe settle at 250 drugs, half of the drug marketplace being covered, high-cost drugs. They don't like very much Speaker Pelosi's proposal that it be a minimum of 25. It gives the Health and Human Services Agency discretion to go 25 to 250. And while they like the fact that it's direct negotiation with penalties if you don't negotiate, if your drug company says, we're not negotiating, you're penalized, they like all of that. They don't like the 25.
On the 25, is it any 25, or is it the 25 that are most highly used?
It's high cost without competitive alternatives. So there's no competition. They're in the marketplace. People don't have viable alternatives, and they're high cost. Okay, that's sort of the standard.
Thank you. Because sometimes we talk about the 25 that are most prescribed, and you sort of figure, well, it may, quote, only be 25, but it covers a pretty significant percentage simply because they're the most commonly prescribed medications. Okay, so this is the 25 that are both high cost and without alternatives.
Right. And again, the Democrats who are skeptical about the Speaker's approach say they don't want to give the administration that much discretion. They'd like to just have a much larger grouping of drugs, similar criteria. You still want to triage this and prioritize based upon cost and availability, but they don't think 25 is near enough.
And I'm guessing that some of the practical politics entail folks saying, look, going to be easier for us to get bipartisan approval if we give that discretion. And by the way, one day there'll be a different administration that could be more favorably disposed to 250.
Exactly. So for instance, the president tweeted a complimentary comment about the Speaker's bill when she unveiled it. He said this, good news, thank you, Speaker Pelosi. Senator McConnell is calling it socialism. So there's hard resistance in the Senate, but she did get the president to engage with her and to say that this was a step in the right direction, in effect.
Yeah, and just for the record, and forgive me, but I mean, my recollection is that the American Medical Association called Medicare socialism when it was first promoted 50-odd years ago.
That's correct. Yeah. And Speaker Pelosi, just a quick point, in her response said, the Veterans Administration has the authority to negotiate, and no one's calling the Veterans Administration program socialism.
Okay. Thank you. I was interested in whether or not we really could get to yes on this pricing issue somehow this year, and I had the thought that you touched on about whole world's different if we're off having a conversation about impeachment. So to you, Ms. Ellenberg, please.
A slightly different issue that than Byrd is discussing, but since we're talking about drug purchases in general, Renee, can I get an off-agenda report on the California change in the 340B drug pricing?
Yes, we'll go ahead and give you the update. This is something that we're obviously not only tracking and monitoring very closely, but also providing direct input.
Great, thank you. So maybe that should come from council? You can figure that out.
Mr.
We can do it off agenda.
Thank you.
Mr. Margolin, before we let you go, you're always a wealth of information. Thank you again. If I wanted something to be optimistic about on the national health care front over the course of the coming year, what might that thing be? Send us off on a good note today.
Optimism on the national health care front. I would have said drug pricing, and I would have said probably no further adverse legislative action against the ACA, that there's a stalemate on that, which means nothing further of an adverse nature would go forward. But I do go back to my first comment that in this impeachment inquiry environment, sort of all bets are off, and it's much more difficult to predict.
All right. On that cheery note, we'll say thank you very much for being with us
I did
once
my best
again.
to be optimistic.
Optimism is one thing. Candor is, however, always called for. So thank you for that.
Thank you.
And Supervisor Ellenberg, that takes us to the last of our agendized items. And in the absence of any objection, I don't expect there will be one. I'm going to adjourn the meeting until our next regularly scheduled meeting, which is Wednesday, October the 30th, with a reminder again to our friends from Public Health that we'll be looking at the vaping item at that time. Just want to make sure we're teed up to do that with a smooth path towards the 5th of November's board meeting. Thank you all very much. Much appreciated. We are adjourned.